I'm Alicia.
And I'm Liam. We both have OCD. And instead of spiraling alone, we decided to turn our symptoms into a podcast. You're welcome.
Here, we overshare real stories, laugh through the anxiety, and talk to actual experts who can explain why your brain keeps asking, what if I accidentally marry my cousin?
Whether your thing is hand washing, mental rituals, or just silently panicking during normal conversations, congrats. You have found your people.
This is a safe place. Unless you're an intrusive thought, in which case, get in line, buddy. We're booked.
So grab a weighted blanket, cancel your plans for the 5th time, and let's dive in. This is the OCD Confessional.
And yes, we did check this recording 4 times before uploading it.
Today on the OCD Confessional, we are honored to welcome Dr. Stephen Poskar. Dr. Poskar is a leading psychiatrist specializing in the treatment of OCD and related disorders. His work focuses on helping individuals struggling with OCD, body dysmorphic disorder, trichotillomania, hoarding disorder, and skin picking disorder. He is the director of OCD NYC, a specialized treatment center serving patients across Connecticut, New York, New Jersey, Florida, Virginia, and Washington. We are so grateful to have him here to share his expertise, insight, and compassion with our community. So, Dr. Poskar, thanks so much for being on the OCD Confessional.
Thank you guys so much for having me. I really am looking forward to it.
Thanks for being here. We're going to jump right in. Should someone with moderate to severe OCD be on medication?
So it's a great question. And I think it's always kind of hard when we say should, right? You know, as we know, there are some people, even with moderate to severe OCD, that can do the standard therapy, which in OCD is exposure and response prevention, and get really good results. And so, you know, typically when I see somebody with moderate to severe OCD, often I'm thinking that it's more likely than not that medication would be helpful for them. And, you know, and then I really talk to patients about patient preference, right? And so some of this is also about like urgency and timeline, right? So if somebody comes to me, even if they have moderate to severe OCD, but they say like, I'm willing to do therapy alone, I want to try it and give it some time. And then if it's not moving in the right direction, I'll do medicine, which is fine. On the other hand, if somebody comes to me really severe and either they're just really suffering or not functioning, then in that case, usually I want to start them on medicine, you know, and again, you know, therapy is always the most important piece, right? And the best thing the medicine can do is often kind of lower symptoms down enough to allow people to be able to do the therapy. And I think I always go back to with patients, right, that the nice thing about medicine is it's not surgery, right? It's not something we can't undo. So to me, trying medicine is sometimes worthwhile because you'll see, is it helpful to you? If it's not, we stop it. If you're getting side effects and you're not worth it, we stop it. But often people can see it's helpful for them. And then sometimes if people are doing therapy for a while, sometimes we can lower and even stop the medicine and they keep their gain. So again, sometimes medicine's a long-term thing, but sometimes it's just a thing that we need sometimes to get people to be able to kind of take those kind of steps and enter therapy.
We can speak to this a little bit. I think the research shows that the best results come from some combination, right, of medication and therapy, obviously depending on the patient and the circumstances. But overall, I think that's what the literature says. You can correct me if I'm wrong on that. But I did want to ask how you got into this field. How did you get to OCD NYC and why the focus on OCD for you?
Yeah. So first on the research, so this is a contentious issue.
Okay.
Because some research that, you know, and when we were writing kind of, you know, so I wrote the biological treatment guidelines for the OCD Foundation. And when we were writing them, we got pushback from a lot of people, which is great. I mean, people have questions and things. And so depending on like how you look at things, there are some people that would say, I don't know, there are a bunch of studies that show that therapies does just as well as medicine and therapy. Others, not so much. And then it's a question of what's the difference if it's moderate to severe versus more mild? What's the difference between if somebody has comorbid depression with it? So it's a debated subject. For me, I got into this because I had a couple of family members with OCD. I actually never planned on being a doctor ever. I didn't go back to school to do even pre-med till I was 28. And I started med
Wow.
school when I was 30. But I went in and did all this because I realized that I wanted to help people with OCD. And so I really went to medical school knowing this was what I was going to do. I went to medical school for that reason.
As it relates to the research on the combination of medication and therapy, where does heroin fit into that?
Where does what? What'd you say?
Where does heroin fit into that?
Sorry, you'll have to excuse my friend. He had a rough night last night.
Yeah, that is beyond, I think, what the research has delved into.
On a more serious note, a lot of people wonder, they're newly diagnosed with OCD. So I'll give you a little bit of my experience. And Alicia's experience on this was kind of similar, where I was super reluctant to do medication. I actually became kind of obsessed with the thought of the side effects and wanted to avoid those at all costs. And thought, if I take those, very black and white thinking, then this is going to happen. I'm going to have these side effects. My life is actually going to get worse. And so I was really opposed to it. How do you talk to someone who's in that position? They're newly diagnosed. They know they need help, but they're just so reluctant to take medication, almost to a point where it is its own obsession.
Well, I love that you ended on that, right? Like almost like it's its own this obsession. Because I think you want to see, there's normal being afraid of medicine and things like that, and that's a certain conversation. But I also think we have to see when this is just part of an OCD symptom, right? That no matter how much we tell you, no matter how much you keep researching and researching, and you never feel certain, right? Because I think at that point, then, right, part of it is informational, right? Like, so when somebody asks a question about medicine or they're nervous, I want to give them information. But at some point when they've asked me the same question 4 or 5 times, when, and it goes back, then I do want to identify with them. And if they're working with a therapist, to their therapist, is this something we actually have to address also from an OCD perspective, right? And not looking things up and things like that. But again, I think I go back to, what I kind of said a little earlier, which is one of the things I really drive home with people, that have your situation that either one of you had, is it's not surgery. There's nothing we start that we can't stop. And we start things gradually and slowly. And, and part of it's also just being with people. I think one place where this stuff fails is when the doctor doesn't see the patient frequently enough at the beginning if they have medicine anxiety. Because I think sometimes you need to help them get through that at the beginning when they have some side effects, right? Typically the problem is side effects tend to come early with medicine and then go away. But it takes a while to accrue. So it's hard, right? Because at the beginning you might be getting side effects and no benefit.
Yeah.
and so, I think educating them on what the timelines are, educating them on what the side effects are, right? Because if people don't want to take medicine because of certain side effects, I want to make sure these are actually true side effects, right? So people will come in and they'll say, I don't want to be on Prozac because I'm worried about my kidneys. Prozac does not get dealt with by your kidneys. It doesn't do anything for your kidneys. So I want to also make sure, I want to hear their concerns, because some of them just aren't true. And then others do have validity, and then it's going over and explaining those.
How do you decide what to prescribe?
So, with OCD, typically, right, the standard of care is SSRIs. And those are selective serotonin reuptake inhibitors. And those are Zoloft, Prozac, Lexapro, Celexa, Luvox, and Paxil. And, typically in OCD, we often need higher dosages than are used for things like depression or anxiety. There's not a shred of evidence anywhere to show that any SSRI is better than any other for OCD or for anything for that matter.
Wait, can I interrupt you really quick? Is there evidence to show that OCD is a low serotonin issue? Because I think that... No.
So let's talk about that.
Okay. Sorry. If I don't get it out right away, then I forget.
It's a good question. So, you know, so, I think there's thinking that just people have not thought out, right? So we can say that people have OCD and we give them an SSRI, and an SSRI, can cause increased serotonin in the synapse. And therefore, if it works, it must be because they have low serotonin, right?
False.
It really doesn't make any sense, right? So I always tell people, imagine you're an alien or you're coming to Earth and you become a human, you don't know anything.
We don't have to imagine, Doc.
I imagine that every day. I basically am an alien.
and you only sleep for 4 hours, but you don't know what causes tiredness. The next day you wake up tired and they give you coffee and you feel less tired. Did you have low caffeine? No, you have low sleep. Just because something helps doesn't mean it's the cause, right? When you have a headache and you take a Tylenol, you didn't have a headache because you were low on Tylenol. And so, the assumption that that is a mechanism, and when you actually look, people with OCD don't appear to have lower levels of serotonin, nor do people in depression.
So why are we giving them more?
So again, we're starting a chain reaction, right? We're doing something pretty specific, right? Because not all medicines that increase serotonin work for OCD. Right? There are other medicines like Remeron is an antidepressant, anti-anxiety. It increases serotonin. It doesn't treat OCD, right? That OCD seems not to just be treated in particular by things that affect the serotonin reuptake pump. But remember, your body and your brain, these are all interjoining neural circuits. So serotonin is going to affect dopamine and affect glutamate, and glutamate's going to affect this and that, and it's going to go downstream and do a million other things, right? And so all we can say is we know that this starts some cascade of reactions that eventually lead to improvement in OCD symptoms.
We don't really know the mechanism then, right? We just know that the research shows that people who take this tend to do better. And Alicia and I think you're okay with me saying this, right? Alicia, we're both on them.
I think so, Liam, at this point.
At this point, we've really...
That's
Yeah, we've shared a heck of a lot on this podcast, which is good. We're both on them. We both have seen improvement as a result of them, but it sounds like even the experts, you don't really know why. Is that the case?
Well, we have theories. I mean, a couple of things we kind of have a sense of, right? Which is, one of the things we see in people with OCD is kind of what we call a hyperactive brain circuit. Right. And an OCD and there will not be a test on this, but in OCD, these are, called cortico-striatal thalamic cortical loops. And in OCD in particular, the areas in like the cortex are usually like we see hyperactivity in the orbital frontal cortex and the anterior cingulate. And then it goes to an area called your striatum and then to your thalamus and back. And in people with OCD, it looks like these areas are hyperactive. Interestingly, when we treat people with medicine and they get better, often we can see that actually these loops have slowed down. So we kind of know that there's possibly an endpoint of where it's doing things, but exactly how, we don't know. And there are theories, but nobody knows for sure. The interesting thing is when we do therapy and it works, those loops also slow down. And so that's important for people to remember. Some people assume, well, if I have a brain or biological illness, I need medicine. But tons of things change your biology. Learning changes your biology. And therapy changes your biology. So it is not in that way, while you're not taking a biologic medicine, it is absolutely changing your biology.
Mm-hmm.
That's fascinating.
I would say for me, my experience with it is it's allowed me to... I used to get very anxious very quickly, and now it has slowed that down, right? So I don't go into these OCD spirals as fast. I'm able to rationally think things through without being so anxious through the process. And I haven't had a depression episode since I've started. So whether it's helping with depression or anxiety, whatever it's doing, it's allowing my body to have a calmer response.
And that's when people ask me, what am I going to feel, right? Like what's the response feel like? And I kind of always talk about it almost of a lowering of the volume, right? It's not that the OCD goes away,
No.
Well, it's the volume's low. Sometimes I tell people it's like the difference between me poking you in the arm with a pin and then you rolling a sweatshirt down and me poking you. You
Right.
feel it, but it's not as strong, right? People say, yeah, sometimes the thoughts are less. Sometimes the thoughts just don't have the same emotional heft, right? They're just easier for me to let be there and walk past. It's easier for me not to give into compulsions. And again, I think that's what also just allows people that ability now to really engage in the therapy because they have a little bit of everything's a little calmer because sometimes it's just so overwhelming that it's hard to even hear what the therapist is saying.
Yeah, I
Exactly.
like
That's why
think,
your ERP with it is so helpful. You have to.
yeah, I like thinking about it that way, that scaffolding, that's nice. You mentioned that typically the dosages are higher for someone with OCD than with an anxiety disorder or depression. Why is that?
So we don't know again, we don't know exactly why. We know just from, doing this and studying it that people seem to require higher dosages. And it's just remember that, we're probably kind of targeting and hitting different brain areas. And, just like in the same way, on your skin, right? I can kind of touch some of the skin on parts of your body and you barely, feel it. And I can touch areas that are really sensitive. And so there are probably going to be areas of the brain that are more sensitive that you need a lower dosage to get a response, and other areas that are not as sensitive in that way that require a higher dosage. And again, we see this in OCD, and we also see the same thing in one of the other OCD related disorders, body dysmorphic disorder, where we also tend to kind of need the same kind of OCD dosages.
I imagine it gets pretty hard to figure out what's best for someone who has been battling severe OCD for a long time because they don't even know who they are outside of the OCD. And then you medicate them and they're trying to figure out how they should be showing up in situations and respond the numbing versus symptom relief. You know what I mean? Because sometimes you're like, well, I feel really numb, but it's better than feeling bad, but I should feel good. At what point do you say, okay, maybe we need to increase your dose or maybe try something different? How long? I know it's a loaded question. I'm all over the place.
Good question. It's a
Yeah.
great question. So, look, it's first, it's always first you want to kind of try to figure things out, right? So one thing is sometimes when people have been, a certain way for a while, anything different feels wrong.
Right.
And so they don't know, like, well, I don't know, it doesn't feel right, but it does not feel right because it's not your normal, and everything that's not
Right.
your normal might feel weird. And especially like when people, and again, like when people are, one of the things you'll hear, right, is patients say, I can't cry anymore, right? Like,
Ah,
when I'm,
I can't cry anymore.
when I watch sad movies and they're kind of like, I'm like,
And all I do is cry.
like, I'd like to cry every now and then.
Yeah.
And again, so one thing is like thinking like, have you overshot the mark, right? We didn't want them crying all the time. And, we talk about this kind of what some people would call an apathy syndrome, right? From SSRIs and as dosages get higher. And, as dosages get higher, it looks like there's kind of becomes this misbalance between serotonin and things like dopamine and norepinephrine. And, sometimes as serotonin gets higher, it can kind of actually impact levels of those things and inhibit them. So when people do have it, and we do think this is, be caused by the medicine, one of the most common medicines we use is Wellbutrin. And Wellbutrin is an antidepressant. It is one of the antidepressants that is not good for OCD. It doesn't affect.
I started off with that.
Also,
Someone prescribed that to me and it was horrible. My intrusive thoughts were through the roof. I didn't know why. I told Liam, I'm like, this is, and you warned me though, didn't you, Liam? You said,
I
you
did.
should start with that. And I was like, well, I'm trusting the doctor. Meh, meh.
Well, so I talk about this when I lecture a lot, right? It gets confusing because of the language, right? Because we used often things get a name for what we use them for first. And so SSRIs we started using for depression originally. So people just started calling them antidepressants. And then people just like, well, antidepressants work for OCD. But not all, I think all SSRIs are antidepressants. Not all antidepressants are SSRIs. And so I think people just sometimes go, oh, well, it's an antidepressant. But again, The only antidepressants that help OCD are, as far as we know, are things that block the serotonin reuptake pump, things that are serotonin reuptake inhibitors. Wellbutrin is not. Wellbutrin actually inhibits the reuptake of dopamine and norepinephrine. And so it's good for depression, doesn't help with anxiety. Sometimes it actually, in some people, can kind of cause an uptick in anxiety.
It caused one for me.
And, and it's sometimes good for some people with ADHD, often ones who can't tolerate stimulants or other medications.
Yeah, but most people who have OCD also have ADHD. So how do you treat both? Liam and I both have OCD.
Well, it's less than most, but a lot. But we'll talk about it.
Okay.
But again, I think so. Wellbutrin can often help because, again, some of this apathy seems like it's due to kind of an imbalance with the serotonin, dopamine, and norepinephrine. So if you give somebody Wellbutrin and increase the dopamine and norepinephrine, we can often see improvements in that. And it happens to some people. But I also think that sometimes the patients come in, especially artists, and they really worry. They really worry about what if I can't feel sad, or I can't feel this, I can't do my art. Or even being medicated, period. They're like, if it's going to make me anybody different than who I am, I can't do that. This is my, and what most people find is it does quite the opposite. It tends to make you better artists and better.
You're like, then why are you here then? Like what is it that's wrong? If you like the ups and downs, then we have nothing to talk about.
Yeah, but like I said, they like some of it and not others, right? People are ambivalent. And that's always what you do with patients, is working on kind of ambivalence.
You talk about how with some of these medications, probably with all of them, you have to give them time to understand whether or not they're working for you, because those first few weeks, the side effects can be higher and the benefits are not quite delivered yet. So Alicia and I both had our experience with Wellbutrin. She gave it a while. I gave it a while. It was not good. I moved on to something else. I forget what it was even called, but it wasn't an SSRI. And I'll be completely honest, just because this is the way this podcast is, it's the confessional. I was super worried about erectile dysfunction with SSRI. I just became obsessed with the idea that was going to happen to me. And so that was a big part of
Peyronie's.
Dr. Poskar doesn't have any idea why you just said that.
At this point.
OCD got a hold of him and thought he had Peyronie's disease, so he went to the doctor to make sure that his. Yeah. Okay, sorry.
Oh my God. Yeah. Health OCD has been one of my subtypes, Dr. Poskar, as you might be able to tell already. And I became obsessed that I was going to get Peyronie's disease because I'd seen it pop up in a TV show, and I was like, oh my God, what if I have that? It was the whole thing. Right. So you can get the sense that for SSRI, the erectile dysfunction risk really concerned me. And as you say, it's not surgery. I could have just, if that ended up being a problem, I could have just stopped taking it. But OCD wouldn't let me believe that. Eventually.
So I do want to say, like, this is a point that we talked about earlier about educating, right? So one of the common things SSRIs cause are sexual side effects. Erectile dysfunction is not common, right, with SSRIs. What's common with SSRIs, right, the most common sexual side effect, both for men and women, is anorgasmia, right? A delayed orgasm phase. It takes a really long time. And the second behind that is lowering libido and sexual interest. Erectile dysfunction happens, but it's not common it's not a super common thing. Again, that goes back to like making sure you educate the patient on like, no, there are side effects but these are the more common ones. These are kind of less common.
Yeah. It was just like, for me, if it was a 1% chance, even I was locked into that. But, ultimately I decided, you know what? My life is in horrible shape. Even if I end up with ED, I'm going to do this. So I did. And then my first 2 weeks were tough with, fortunately, with not those side effects, but just headaches, sleeplessness, some muscle cramping. But I waited it out. And about 6 weeks in, I had this kind of light bulb moment of one day where I was like, wow, everything's a little quieter in here. How long do you recommend typically people give it to see that impact before you're willing to say, all right, let's move to something else?
So it's a great question. So remember, we don't know what your dosage is going to be ahead of time, right? So, we know kind of estimates of typical dosages that work for OCD. So when you get to a dosage that you think is a high enough dosage that it could work for OCD, you usually want to give it 4 to 6 weeks at that dosage, right? The getting there doesn't count, right? It's at that dosage. After 4 to 6 weeks, I usually want to see something. Right? Not everything, not whatever, but you're telling me that something's different. If something's different after 4 to 6 weeks, then I usually keep my hands off of it, even if it's small, because we often see these grow over time. If at 4 to 6 weeks, I don't see anything and they're tolerating it well, then I'm going to go to a higher dose, right? And so you want to kind of get them to a decent dose. And if you still see nothing at a fairly high dose, or they're getting side effects because of dosage, then you might want to switch to another agent. But one of the problems we typically see, right, when you do this specifically is patients come to me and they say, I've been on Prozac and I've been on Zoloft and I've been on whatever. And then I say, how long were you on them and at what dosage and for how long? Because often they haven't been on very high dosages. They either haven't been on OCD dosages or maybe they're in the low end of what could be OCD dosages. And so it's making sure that you're actually using kind of, again, those kind of upper dosages, before you give up on a drug.
We're going to pause for a moment because this part of the conversation is brought to you by our partners, NoCD.
The same distressing, unwanted thoughts keep playing over and over in your mind. The same rituals keep eating up your time, holding you back from enjoying your life. You've tried talk therapy before and spent session after session diving into those thoughts, trying to understand them, trying to fix them, but somehow they just get worse. And the shame piles on because you think, why isn't this working? What's wrong with me? If this sounds familiar, here's what you need to know. You are not the problem. You're experiencing something that a lot of people with OCD experience. Getting your life back is possible because OCD is highly treatable. It just requires a completely different approach than other mental health conditions. In fact, standard talk therapy often makes OCD worse because it encourages you to analyze those intrusive thoughts or try to replace them with positive ones. But with OCD, the more attention you give the thoughts, the stickier they become. That's where NoCD comes in. NoCD provides virtual therapy designed specifically for OCD. Every single one of their therapists is extensively trained in a type of therapy called ERP, or exposure and response prevention, which is the most effective treatment available for OCD. And they get their training from world-renowned OCD experts, so they truly understand what you're dealing with, even the stuff that feels impossible to say out loud. In live, face-to-face virtual sessions, your NoCD therapist will teach you how to take the power away from intrusive thoughts so you can live the life you want to live. In between sessions, you'll be able to message your therapist anytime, join dozens of live support groups, and continue your progress with other expert-developed therapy tools. NoCD is also covered by insurance for over 138 million Americans, and their team makes it really simple to get started. Visit nocd.com and book a free 15-minute call. That's nocd.com to learn more and talk to someone who can help, because you deserve treatment that actually works for OCD. And now, back to our show.
How do you decide when it's time for someone to wean off? And do you recommend that at some point if they are doing therapy with medication? When do you know it's time to maybe...
So look, there are a lot of people with OCD that stay on SSRIs for their life. And because they just do well on them, and we know that when we stop them, there's a high relapse rate. I think there's this group of people where we start them on SSRIs, and then they really push the therapy and they're doing well. And it's hard to know what's doing what. Do they need the SSRI? And then if you're going to lower an SSRI, you do it incredibly slowly, right? Because I want to catch it if it gets a little worse, right? So I might lower, a Prozac if somebody's on 80 milligrams of Prozac. I'm going to lower it to 70 for 2 months because I don't see the effect. Just like it takes a while for the drug to work, it doesn't unwork right away, right? And so I want to see what you really look like on 70. I want a couple months. If you're doing okay, I'll drop it. And I just keep dropping it till either you're off of it Or you might get to a point where we drop it and you're good, and you drop it and we're good, and then we drop it beyond a certain point and you go, I don't feel so great. In which case we got you to a lower dose. But I also think, when people are deciding whether to be on something or not, right, it's what's the upside, what's the downside. So, it's going to be much more likely that someone's going to want to lower or their dosages, that they might say like, hey, look, it's been working for me, but I've been pushing real hard in therapy, but like I've gained 15 pounds and I'm having sexual functioning issues. Can we try to get off this? There are other people that say, I tolerate this really well. I feel good with the combination. There's no data to support that it's harmful in any way. And, we have a decent amount of data now because Prozac's been out, for 40 plus years. And so, it's everybody's different. And again, you can always do a trial, and you just do a trial of lowering slowly, and then you see.
I did want to ask about the long-term effects because, I've wondered myself, am I going to be on this the rest of my life? Is there some point at which maybe it makes sense to wean? I haven't looked at the research myself, but what does the research say about possible long-term effects of high doses of SSRIs?
So, I don't think we know as much about long-term effects of high doses of SSRIs, right? Just because I don't think it's studied very much for very long. But there's nothing in what we've seen, and we have been doing it for a while, in the high doses or regular doses of SSRIs that appear to be kind of long-term problematic side effects that lead to, people dying any sooner, being sicker, any kind of disease process. And I think something to remember is, there are things that actually really get in the way of your health. Anybody who does this stuff or anything will tell you that stress, cortisol, all of those things aren't good for us. So, not only doesn't it appear to be harmful, but I think in a lot of cases we might find again that it's actually helpful, right? It's decreasing stress, it's decreasing anxiety, it's decreasing things that actually we do know for sure are destructive for your health. Remember, we've had people on Prozac now for 40 years. There doesn't seem to be any kind of signs that there's any long-term effects at this point.
Yeah. I mean, if you have an imbalance and your body needs it and you are, better on the medication. I mean, it's like people with diabetes. If you need insulin, that's what your body needs because it's not producing it on its own. And therefore I guess for me, knowing that it's OCD related, my depression and anxiety was probably a result of my OCD. I don't want to be on medication forever. So I am worried about weaning myself off. But yeah, I don't know. It's tough.
That's why you want to be doing this with a professional that actually knows what they're doing and, and explains everything to you so you know what they're doing. Right.
Yeah.
And that's again, there are ways to do things. There's ways to get people off medicine. One of them is making sure you're doing it unbelievably slowly so that if there are problems, right, you catch them early. You don't, do it so quickly that suddenly the patient goes from here and suddenly a week later they're in the floor. So,
well, that and the medication convinces us that we're better. That we can get off of it, but you're like, no, that's actually the medication making you feel better.
But like you say, you don't know, right? You don't know for sure, especially when you're in therapy. Like what's doing what at this, it's very hard for people to tell. I ask people all the time when they come see me, when I'm seeing them for the first time and they're on medicine or they've been on certain medicines, then I'll ask them like, did you find this helpful or not? And I'm not sure is a completely legitimate answer to any question. Because sometimes people aren't. They're just like, I don't know. I was helped maybe at the beginning, and then I don't know if it was helping. And also my life circumstances got better. And, and I'm in therapy. And it's hard to know. There's lots of variables. And so I don't know that anybody could always know for sure what's doing what. And again, sometimes the only way to figure that out is to changing something. But when you change something, you change it slowly. You watch carefully. That's the way you make changes, right? And in a safe manner.
I want to ask you a little bit about alternatives to the, SSRIs and kind of pharmaceutical medication. And you might not have any, background on this, so feel free to say, you just don't feel qualified to talk about it. But there is growing chatter online in OCD communities about psilocybin for potentially OCD treatment, depression, anxiety.
I thought you were
What are
going to
your
say
thoughts?
inositol.
Inositol?
Inositol.
Oh,
L-theanine,
psilocybin.
magnesium. Nope. Liam's going straight to the mushrooms.
Straight to the hard stuff.
Yeah, so I try to preface it, but I try not to give my thoughts. I try to tell people what the actual research shows. And
Okay.
so, the psilocybin study is being done by Christopher Pittenger at Yale. And his group has been looking at psilocybin. I think they have some nice preliminary data. And I think Dr. Pittenger would tell everybody, nobody should be taking psilocybin for OCD right now. Nobody should be doing it on their own. Nobody should be seeing anybody. We don't know enough yet. We are not there as far as how to dose it, what this scenario has to be, how often. It's the patient population that it works for and doesn't. So again, part of the problem is with this stuff is people look at it and they get ahead of the curve, and then people just start saying, all right, I'm going to get psilocybin from somebody. I'm going to go to or there are people or clinics or whatever, and they do it. And, as we know, like, these aren't medicines that literally don't have negative effects. People can have really horrible experiences on psilocybin. So I think it looks like it's promising for a bunch of things. In OCD, I think, again, my guess is Dr. Pittenger will probably talk about it at the OCD conference this summer and where they're at.
Oh,
He always does.
Just bring some to hand out to the audience, Liam, and let everyone just... Can you imagine a bunch of people with OCD on psilocybin at an event? So there is record of people saying they have short-term relief, right? But the long-term effects of it, and what are they supposed to microdose every day to feel good? And I mean, that's just opening up.
There's also stories for everything, right? I mean, look,
Yeah.
there are plenty of people who tell you when they drink, their OCD is better in the short term.
Right.
And so again, this is why we have research.
On the research question, I'm curious what the setting is, or kind of what it is that they are researching. Are they researching macro doses where you are with a clinician during your experience? Are they researching micro doses that you're taking daily or semi-regularly? And
no real data to support microdosing. It doesn't actually look like it does very much, despite, again, the chatter on the internet and things like that. So I don't know the exact dosages they use. I know pretty much as I remember that people are getting a dosage and then they stay there for a while and they're kind of getting seen daily, and they're doing it with a team and a therapist. These are not people that are giving you psilocybin and sending you home and saying, come back in a week. So it's a fairly controlled setting. At this point in time, again, I don't want to overspeak because I'm doing this from memory, but as I remember, I think they were there for a few days, sometimes 4 or 5 days after the dose, and kind of, being monitored. And so again, it's just, it's something, again, that, the problem is people get a whiff of this stuff and then a bunch of people just start doing it way before we know how to do it safely, how well it works. And that's always a scary thing.
yeah,
You have something to confess, Liam?
No, nothing to confess. I wanted to ask the same question about MDMA. We've seen that specifically with PTSD. I know there's a lot of research into PTSD. Is there any research that you know of happening as relates to OCD?
Yeah, I think Caroline Rodriguez's group at Stanford is looking at it, if I'm not mistaken. I don't know where they are with it. Again, I could be wrong, but I'm pretty sure, again, and Caroline will be at the conference as well. It's funny. We do every year we do an Ask the Experts panel about medicine, and every year there are a million questions, but there's so many questions about psychedelics. So if anybody's going to come to the conference, those questions will be asked, and you'll have really the best people.
I'm going to be in the audience asking every question. You know what I think it is that OCD is such a miserable experience that people are desperate for a fix, right? And SSRIs definitely have provided for me a lot of relief. They got me, I would say, 50% of the way there, somewhere around there. And then therapy has gotten me a long ways as well. I've been in ERP for the last, I don't know, how long has it been, Alicia? 4 or 5 months. And I've definitely had relief from that as well. But if you can find, I think that appeal of some natural solution. Now I take this and it's fun and I take it and I can learn something about myself. And then I wake up the next morning and maybe my OCD isn't there or not as strong. Like that's super, super appealing. And that's why I imagine people are showing up at the conference going, let me talk to the person researching MDMA or psilocybin. Like, yeah, sign me up.
That's what leads to addiction, Liam.
Valid.
That's why people with ADHD drink alcohol, because it gives them the relief. That doesn't mean that that's the solution.
But I think this is right. This is always tough, right? Because first of all, I think people's vision of how this would work and how it works are different. I think people hear the stories about people who are hardcore drug addicts and they go to the Amazon and they have one experience and after the experience it's just gone and I'm sure that happens. It's not typically the way these things work. So I think also kind of the dream of how it would work is very appealing. Right.
Definitely.
I think we don't really know that. And I also just am very careful with, when people start using the word natural, I think it's again, remember, there are places where you can go into the woods and eat these very pretty berries and they kill you. So natural has this kind of thing that somehow safety and natural go together.
Okay, so sum up for our listeners your top 3 recommendations for OCD medications, and then your absolutely stay away from, like Wellbutrin. Had I known, I wish I would have. What are your top 3 recommendations for OCD?
So again, I would say, look, if you have OCD, there's pretty, you should be on a serotonergic reuptake inhibitor, which are the SSRIs. If they don't work, sometimes we try another SRI, which isn't an SSRI. It's what's called a tricyclic, which is called clomipramide or anafranil. And so, if you're being treated pharmacologically, that should always, again, unless there's something happening where you have bipolar disorder as well, but generally people should be started on an SRI. And you want to make sure that the dose is high enough and that you're on it for a long enough period of time to judge it, right? Because there are tons of people on them, but the dose isn't high enough. I think the other thing is there are some augmentation strategies, but again, they shouldn't be tried until you've kind of been maximized on an SSRI. Often people will give low doses of an SSRI and it's not helping, and they start adding other drugs that have more side effects like antipsychotics before they've really actually done what they're supposed to do.
Is the dosage based on the severity of the OCD or the symptoms that they're coming to you with? Because we just upped mine and I don't love the way that I feel. So how long should I deal with the new side effects before I realize that maybe the dose was too high and I go back down?
Well, it depends again, I have to know in particular what side effects we're talking about, right? Some side effects people get better with, some don't.
Okay, so some do get better and some don't.
So just monitoring that and, but I think, again, I think there's no relationship to severity and dosage. It's not that people need higher dosage if their OCD is more severe, there's no relationship. There's no relationship to even if somebody's somewhat what we'd call it has low insight, needing a different dose. It's just some people, because of their brains, their bodies, they need a little higher than somebody else. We all break things down differently.
Right.
And, I think making sure that like kind of those things are intact, but I think also like, to me, the biggest thing is making sure that you understand everything. If a doctor's not explaining things to you in a way that you can understand and you don't have all your questions answered, this isn't a good doctor for you. And I think, and that's really important, to make sure you feel comfortable, you understand things. And again, I think the other most important thing I would say, because I think it's important when you're talking about this stuff, and I know you guys have dealt with these things and brought up, is it's also, remember, if a medicine's not working for OCD, sometimes the reason is because they have other comorbid disorders that aren't being treated. So with ADHD, I can do everything I want for the OCD, but until I treat the ADHD, it's hard to get under control. Other people might have bipolar illness. So sometimes I see patients and they say the refractory OCD patient's nothing working. And then I see them and I say, yeah, but did anybody else tell you you have this and that you have this? So that's another reason patients might not be responding the way you expect. And so really making sure, sometimes people come in and say, I have OCD, and they just go from there, as opposed to, you need a full diagnostic interview, everybody, consultation, to see what else could be going on. Because I also have to check people, are they taking drugs, right? There are some people that if they're smoking pot every day, I can do whatever I want and the needle doesn't move. So you really have to know the whole picture, what they're taking, what other diagnoses they have, what other medical stuff, because often the reason people don't succeed is because there are other things going on.
Right. That just touched off so many questions for me. One,
I'm
THC. So the THC, I used to use THC maybe like twice a week. And I was like, oh, this is cutting the edge for me at night. It was especially like during COVID, I want to say I was using it a fair amount just because, boy, life was boring. And so you'd spice it up a little bit, take the edge off. Then over time, I found I was waking up the next day, I was much more anxious. At least that was how I believed I was reacting to it. And so I stopped using it. Are you saying that can inhibit the impact of an SSRI?
I think that there are tons of patients, and again, what the dosage is, it's hard to know, right? Is once a month not a problem, but once a week is, or is once a week not a problem? I can just tell you that, I continually have seen that when you try to treat people, whether it's for depression, anxiety, OCD with SSRIs, and they're regular pot smokers, the amount of times you get a response is significantly less.
Wow.
So then do you recommend that they quit smoking pot? I mean, that person's probably so dependent thinking that was helpful, and now they have to go through the withdrawals of that and then start a new medication. What do you do?
I often tend to not even do anything else until they're off of the pot.
Yeah.
Because I don't know who that person is. I know who that person on pot is, right? So even being able to judge what their symptoms are and everything. And remember, one of the problems with cannabis is people use it slowly over years. And if you ask them, is it affecting you negatively? They will often say no. But once you do a trial of getting off it and they're off it for a couple of months, they will say, I sleep better. I have more energy. My mood is better. And so it's one of those things that I think sneaks up on people, so they don't know the effects that cannabis is having on them.
Yeah, really interesting. The other thing you mentioned was ADHD and OCD. So we've had this conversation a few times on this podcast, but I think it's worth revisiting. Alicia and I are both diagnosed with both ADHD and OCD. And since being diagnosed with OCD, I've often wondered if actually I'm not ADHD at all, and that the attention deficit stuff that was showing up for me was much more a result of the fact that I was in my head constantly with horrible intrusive thoughts and ruminations and mental compulsions, and that I, as a result of that, appeared distracted and would miss things, which I still do. I still miss things now, but I don't know that I actually have ADHD anymore. Like, I've met other people with ADHD. I have a very good friend who has ADHD, and I see her functioning in the world, and I'm like, I don't know if I have ADHD. This person is way beyond my level of attention deficit. So anyway, what are your thoughts on that? That some people are being diagnosed with both of these things, and maybe the OCD is causing what looks like ADHD.
Well, I think one of the problems with ADHD is the diagnosis has the word attention in it. So the second people have attention issues, people are like, oh, you must have ADHD. The problem is almost every psychiatric disorder, one of the symptoms is inattention, right? One of the diagnostic criteria for depression is poor attention. In bipolar disorder, of distractibility, in generalized anxiety, poor concentration and focus. And so I think, you have to be careful, that just somebody having something I have inattention does not mean they have ADHD. Right. And so you really need to do a full diagnostic of ADHD. And you also need to ask them questions, right? Like, well, tell me what's going on in those periods of time. Is it because you're lost in your head going over a thought or kind of doing this stuff? So I think people sometimes, and I think ADHD is something that is both overdiagnosed and underdiagnosed.
Wow.
I think there are plenty of people that don't have ADHD but have given the diagnosis. And I think there are plenty of people that have ADHD that have never been diagnosed. And so I think something people talk about is this over or under. Things can be both. And so, a lot of people that I've treated for OCD that don't respond, it's because they also had ADHD. And if you think about it, right, if you have ADHD and one of the symptoms is impulsivity, right? So it's hard for you to not give in to impulses. How would you be able to resist compulsions? You can't not like yelling and screaming in class. How is he going to resist a compulsion? And if somebody's got ADHD and their thoughts are already disorganized, how are they going to be able to step back from the OCD in any way? And so often you'll see if you treat the ADHD, even if you treat it first and do nothing else, you find some of the OCD just improves from that.
How do you treat ADHD?
So ADHD is, the kind of standard has always been stimulants. Stimulants come in basically two flavors, right? They are either amphetamine based, and those are things like dextroamphetamine, Adderall, Adderall XR, Vyvanse, or they're Ritalin based, and Ritalin is known as methylphenidate. So there's short acting Ritalin, Ritalin LA, long acting Ritalin, which is Concerta. And so both both are stimulants. There's not a lot of evidence that one's better than the other. And so those are the standard treatments. Not everybody tolerates those. Either sometimes it does make somebody's anxiety worse. Every now and then
I was just going to ask, couldn't a stimulant make your OCD worse? I've worried about that.
Yeah. It used to be that people would say that, like almost like it was a fact. There are definitely cases where it can make people worse. We've also done studies on stimulants in people with OCD without ADHD, just for OCD that have been successful. Lauren Corin did studies years ago, and not a lot of people followed up on them. But there have been several studies just using stimulants and for OCD. And I think at ADHD, OCD, they're often really helpful. There is a small cohort who have like OCD or tics, and that sometimes they just make them worse. But it depends also, sometimes if I'm treating them with an SSRI as well. But again, and so if people can't tolerate stimulants, we have other treatments, non-stimulant treatments, things like Strattera, Wellbutrin, both can work for ADHD. They're not as strong as the stimulants are, but they tend to sometimes be a little bit more side effect friendly. So depending on the case.
Do you think psychiatric meds are overly prescribed?
Again, I'm going to probably give you the boring same answer. I think they're overprescribed and underprescribed. I think there are people that are on them that don't need to be. And I think there are tons of people whose lives are being destroyed because they're not on them. And I think it goes both ways. I think, and that's why, we have like kind of criteria for which we're supposed to be prescribing things, and not everybody follows those. And, some people just, anytime somebody feels an emotion, will throw a pill at them. And, having normal.
Or in my experience, trust a doctor who isn't aware of what OCD actually is. And when I tell him I have OCD and he prescribes Wellbutrin, we have a problem.
Yeah. Well, and again, I think this is just another thing that people don't do enough, which is it's okay as a doctor to say at some point, this falls out of my area. I'm going to, because you came to me, I'm going to find you the person that's better to deal with this than I am. And sometimes doctors just try to do stuff that they don't know at the expense of the patient. And I don't want a doctor practicing on my family. And so,
let the ego go.
Yeah. So when there are things that I'm not the best at treating, or people come, I will help them and I will find them somebody to go see and things like that. But unfortunately, I don't think that's done enough.
But Dr. Poskar famously does do heart surgeries, though.
It's a hobby, not like a friends and family.
It's a hobby. Some do woodworking, he does heart surgery. As kind of a last question, because we've taken up a lot of your time. Some people still really feel shame about being medicated for OCD or any number of mental health issues. Why do you think medication still carries that stigma, even within the mental health community? You'll hear from people who are like, no, I was able to do it with therapy. You should just do it with therapy, or, exercise more, eat better, drink more water. You hear all these things. And I've certainly felt the shame around it, whether that's internal or external. So what are your thoughts on that?
Well, I think a few things. I think, we have to take one step further back, right? And say, not why is it a shame of medicine, but why is it a shame of mental illness? And I think one of the problems with mental illness, in my opinion, is that they sound like things that other people experience. So people would say, okay, I have depression, I'm on medicine. And somebody will say, I was depressed and down for a while, but I just kind of pushed through. And they're comparing being sad and down to major depressive disorder. They're not the same thing, right? Or somebody saying, hey, I am anxious and I just kind of pushed through it, but that's not the same thing as having OCD or generalized anxiety disorder or panic disorder. So I think because people talk like that, I think then patients think, oh, this is a weakness, right? I'm just not strong I'm not pushing enough. And I think, patients realizing this is a medical disorder of the brain. Would people feel, kind of shame about taking medicines for migraine headaches, right? And again, it's just this somehow that these have been thought of as this separate category. But, like you said, I don't know. There are some people with high cholesterol and high blood pressure that can do diet and exercise and it works. I hope people don't feel shame if that doesn't do it alone and they need blood pressure medicine or cholesterol medicine. And so, I think, to me, I don't look at these as any different than any other medical disorder. And I think when you do, then you start kind of thinking about medicine differently. But again, and that doesn't mean, again, it's, part of also, I think part of the problem is it's good. It's a lot of people can do therapy alone, but it's the responsibility of a therapist or anybody you go see for OCD to tell you what the full treatments are, right? So to let you know, vice versa, right? This happens in medicine all the time. Most psychiatrists don't even know what exposure therapy is.
No, you're right.
You say you have OCD, and if they'll give you an SSRI, and they'll never tell you that. Well, it's both on both sides. It's your responsibility to give informed consent, which is what you want, what the treatments are, what the downsides are. And I think that's, really important, and not to put your own stuff into that when you're treating a patient.
That is really important. If someone listening right now feels hopeless because medications haven't worked for them, what is something that you would like for them to hear?
So I think that most people who medications haven't worked for, they often just haven't been given the kind of, type of medication treatment that can help. Most people that come to me, I rarely see people that, have never been on meds before. I do occasionally. Most of the cases I see are people that have been on multiple meds, they haven't worked. And usually, we can do something to get them better. So I think, and that is where you want to maybe go see a specialist, right? That, you get to a point, generalist is fine for things. But when it gets to a level that goes beyond that, that's the point you might want to find somebody that really does OCD, work full time.
Dr. Stephen Poskar of OCD NYC, thank you so much for putting up with our foolishness for an hour and humoring us, even with our crazy questions.
Yeah, that was really good.
It's been a pleasure. And thank you guys so much for doing this cast. I mean, it's a huge thing for people to know they're not alone and to see people that are smart and funny and have great, full lives despite their OCD. So thanks so much for doing this.
We'll see you in Seattle.
See you in Seattle.
I'm in the thick of this move, which, by the way, you guys listening, if you've been following along this journey, we made a decision. My family is moving to Kansas City. from Southern California. And to say I am facing the most uncertain time of my life would be an understatement, because we are blowing up our life as we know it in a good way and restarting. So we're going to pivot and lean into some other opportunities out there and be with our family and have that support and raise our kids with my in-laws and cousins and uncles and all the things. So we're very excited now that the decision fatigue is over and we can lean into that decision confidently. I'm feeling really good about it.
And for people who've been following along, Alicia and Spence had been looking for houses in the area in Southern California where they are. And it was just insane. It was like $1 million for a shithole.
1.2 million will get you nothing out here. And at some point you have to just say, okay, like, I'm done with the rat race. There's a lot of things I love about where we live, and there's a lot of things I'm really excited to not experience anymore. So yeah, it's wild though. I've been in LA, I've been in Hermosa for 13 years, in California for over 20. So this
My
is the
God.
biggest life-changing thing. Yeah. I don't
It's
even
gonna be
own a
culture
boat.
shock.
I don't know how to function in the cold. It's wild. But there's so many things to look forward to. So I'm just focusing on the positive and trying not to worry, because we all know where that gets us. I'd be lying if I said that there wasn't a lot of those popping up. I think I shared before that you can't play God. You just have to make the decision and go with it and not think about worst case scenario. So that's what I'm doing.
Yeah. Your fear is that in making this decision, you have now somehow set in motion a chain of events that will lead to the death of one of your children, for instance. That, like,
Yeah,
because you're moving to Kansas.
Saying that out loud, because it will happen if you say it. So can we not?
Oh, so now I have to say it, and you need to sit with the distress.
You know how I want to reframe that is, if I stay in California, then maybe something would happen. I'm leaving because I'm
Just don't know.
You know, we don't know. We don't know. And I'm going to be okay with that, because that is life, and life is full of uncertainty and change. And so there we have it.
Thanks for listening to another episode of the OCD Confessional. Be sure to follow this show so you get new episodes. You can subscribe to us on YouTube or find us on Instagram and TikTok at the OCD Confessional.